Okay, hi guys, now that we are live. So today's discussion would be on glaucoma. So, glaucoma quiz discussion, shall we start? Yes? Okay, so the first question is a very basic question related to anatomy and physiology, which talks about the maximum resistance to aqueous outflow is at. And the options are option A, Schlemm's canal, option B, uveal part of trabecular meshwork, corneoscleral part of trabecular meshwork, juxtacanalicular part of trabecular meshwork. So basically option A is Schlemm's canal and B, C, D are the different parts of the trabecular meshwork. Okay, so the anatomically different parts of the trabecular meshwork. So where is the maximum resistance to aqueous outflow? Meaning because of that resistance, the intraocular pressure is generated. All of you know about the IOP. So the IOP is generated because of the resistance to this aqueous outflow. Where is it maximum? Only one answer. Okay, juxtacanalicular part of trabecular meshwork, because the pore size is very small in the juxtacanalicular portion of trabecular meshwork. All right. Okay. Now moving on to question number 2. Ocular hypertension increases the risk of OHT. What is OHT? Ocular hypertension is not glaucoma. Okay, ocular hypertension is not glaucoma, wherein it's just the intraocular pressure that is raised. So your optic disc is normal, visual field is absolutely normal. If you look at the RNFL, the retinal nerve fiber layer on OCT, again it doesn't show any change. Okay, so glaucomatous criteria are completely absent. The only thing that is present is intraocular pressure that is increased in case of ocular hypertension. So they are asking OHT increases the risk of. Option A, central retinal artery occlusion, no. See, transient rise in a very extraordinary rise in intraocular pressure, yes, it can cause a CRAO like situation, but OHT itself does not increase the risk. Okay. Option B, CRVO, which is actually the answer. So ocular hypertension increases the risk of central retinal vein occlusion. Okay. Option C, keratoconus, na. Option D, ARMD, age-related macular degeneration, again no. Okay, question number 3. The double angulation of retinal vessel at the disc is called. So what is this double angulation that we are talking about? The sharp angulation of the retinal vessel at the margin. So this one, it can happen anywhere. Okay, it can happen in the superior rim or the inferior rim. So already you can see there is nasalization of the vessels. The NRR is completely thinned out. This is the optic disc that we are looking at. Guys, this optic disc is nothing but the intraocular portion of the optic nerve. Okay. So in glaucoma, you can see the neuroretinal rim very thinned out, and you can see a sharp angulation of the vessel at the rim. Okay, so here there is no double angulation because there's so much of NRR loss that you can see the just that abrupt angulation. Okay, so that is the bayoneting sign. Okay, so bayoneting sign you can see in the inferior rim or the superior rim. So in this case you're seeing it in the inferior rim. Okay, so this is the bayoneting sign and this is the optic disc change of glaucoma. Okay, so all right, now what about so the question is very simple. Double angulation of the retinal vessel at the disc is called bayoneting sign. Now option A, bonnet sign. See, bonnet sign is seen in hypertensive retinopathy where you have a distal banking of the retinal veins. That is bonnet sign and it is seen in hypertensive retinopathy, not in glaucoma. And bean pot cupping, yes, the same thing, the same optic disc. When you're seeing under a stereoptic view, either on slit lamp with your 90D or 78D, or you're looking under even indirect ophthalmoscope, then when you have a stereopsis, you'll see the bean pot cupping. But the classical description that I gave in the worded question, that is not bean pot cupping. Okay, although bean pot cupping is seen in glaucoma. Option D, isn't rule. See, isn't rule actually describes the normal neuroretinal rim thickness, nothing to do with glaucoma as such, the isn't rule itself. Yeah. So isn't rule is broken in glaucoma. Yeah. Hi Neil. Hello beta. Alright. Now question number 4. The earliest visually significant visual field defect in glaucoma. It's a very straightforward question. Let's look at the options though. If have they given anything out of the usual norm? Arcuate scotoma, ring scotoma, nasal step, paracentral scotoma. Paracentral scotoma is the answer. Okay. So the earliest visually significant field defect in glaucoma is paracentral scotoma, followed by your Siedel's sickle-shaped scotoma, then would be your arcuate scotoma, Bierum's arcuate scotoma, then would be the ring scotoma. So the earliest visually significant would be paracentral scotoma. Okay, question number 5. Anterior chamber depth can be objectively measured by all except. See, AC depth can be objectively measured by all except. Option A, Van Herrick method. Yes, Van Herrick method we can measure, but it is a very subjective method. Horn slit lamp, very subjective. So the question is, it specifically asks objectively measured. Van Herrick method is a subjective measurement. So that's the answer. Let's see, that means what are the objective ways of measuring anterior chamber depth. Number 1, anterior segment OCT, yes. Number 2, UBM, that is ultra biomicroscopy, yes, we can measure on IOL master as well. So these are the 3 ways where objectively you can measure anterior chamber depth. What all? Anterior segment OCT, UBM, that is ultra biomicroscopy, and IOL master. Okay, now instruments regarding glaucoma is very important. Tonometer, so there is definitely one question on tonometer. Portable tonometer that uses prisms. Option A, tone. Okay, so that's not the answer. Perkins tonometer, yes, very many of you have marked it correctly. Yes, correct. That is the answer. Goldman's tonometer. See, Goldman's tonometer is not portable. No, it is an attachment on the slit lamp. How is it portable? Maybe from one room to the other, maybe you can shift, but otherwise it's not portable. You can't carry it around. Yes, it uses prisms, but it is not. And Schiot's tonometer, it is portable, but it doesn't use prism. No. So the answer to this question, which is portable tonometer which uses prisms, is your Perkins handheld tonometer, applanation tonometer. Now treatment of choice in acute primary angle closure. Acute primary angle closure, APAC. Okay, acute primary angle closure is the recent nomenclature for your acute congestive glaucoma or your acute attack of angle closure. Treatment of choice, when you make that opening on the iris, that is laser peripheral iridotomy. Okay, so pilocarpine, no, that's a drug of choice for APAC. Yes, mannitol, it is not the treatment of choice nor the drug of choice. Acetazolamide, neither treatment of choice nor the drug of choice. Yes, it is used to reduce IOP, but it is not the treatment of choice nor the drug of choice. Yeah, laser peripheral iridotomy, that is a treatment of choice for acute congestive glaucoma or your acute primary angle closure. Alright, now the next question is, which of the following reduces episcleral venous pressure? What is your episcleral venous pressure normally? It's a little lesser than your IOP, it's around 6 to 8 millimeter mercury. So if you reduce the EVP, the episcleral venous pressure, obviously the IOP will come down. And which drug? The Rho kinase inhibitors. Okay, so let's see if there's a Rho kinase inhibitors among the options. Option A, timolol. No, it's not a Rho kinase inhibitors, it's a beta blocker. Latanoprost, it's a prostaglandin F2 alpha analog. No, that increases uveoscleral outflow. Netasudil, yes, that is a Rho kinase inhibitor and it is going to decrease episcleral venous pressure. Option D, acetazolamide. Acetazolamide, you all know, it is a carbonic anhydrase inhibitor. Yeah. So, which is going to again decrease aqueous production. See, beta blocker and carbonic anhydrase inhibitors, they decrease the aqueous production and thereby the IOP. Rho kinase inhibitors, 3 mechanism of action. 1, it decreases the aqueous production. It increases the trabecular outflow. It decreases the episcleral venous pressure. So, 3 for Rho kinase inhibitor. Okay, so RHO, Rho. 3 mechanisms: decreasing aqueous production, increasing the trabecular, that is a conventional aqueous outflow, and decreasing the episcleral venous pressure. Okay, next is, which of the following drugs may cause secondary angle closure glaucoma? Niacin, no, niacin, I know you all love the drug. The examiners especially love the drug. That causes cystoid macular edema. It doesn't cause glaucoma. Tamoxifen causes corneal complications, retinal deposits, but not angle closure glaucoma. Topiramate, yes, topiramate causes secondary angle closure glaucoma because it is a sulfonamide. So what it causes is it causes a ciliary body effusion. So when there is ciliary body edema, what happens is there is an anterior rotation of ciliary body. So when there is an anterior rotation of the pars plicata, especially the pars plicata area, the lens will move along with it anteriorly and the iris will be pushed forward. So when the iris is pushed forward, you get an angle closure. Okay. So topiramate causes secondary angle closure glaucoma. Rifabutin, you all know it causes drug-induced uveitis. All right. Now, antimetabolite used in trabeculectomy. Paclitaxel, no way. Mitomycin C, yes, that is the most commonly used metabolite used in trabeculectomy. Yes. Fibrin is tissue glue. Why would that be used? Fibrin glue may be used towards the end to seal the conjunctiva, maybe, rather than putting the sutures. But again, we do put sutures. There is a fibrin glue that may be used. Bevacizumab is an anti-VEGF. It's not an anti-metabolite. So the anti-metabolite that is used in trabeculectomy most commonly is mitomycin C. We may also use 5-fluorouracil. Okay, can be used. All right. So thereby we complete discussion of the 10 questions of today's glaucoma quiz. Any other questions regarding glaucoma, bache? Any other questions that you have? Any other doubts? Okay. Any other questions on glaucoma? Any doubts? Any questions? What, Monday morning blues for everyone? Looks like. Okay. All right. So we'll wind up the discussion. Watch the discussion. If you have any doubts, you can put the doubt under the comment section. And today I've posted a clinical question on Instagram. Again, EyeMentor Dr.Rajarathna. Please go through both the pictures. There is a clinical picture of the eye and there is a CT image, and I've given the options in the caption. So take a look at the options. It's not an open-ended question, and also there is a hint in the options. So take a look, okay, read it and answer, give your answers there. All right. So that question probably tomorrow I will discuss with you. Okay, that clinical case tomorrow I will discuss with you. All right, guys. See you all. Bye-bye.